we'll go do a quick review on the first session, and for the people who did not attend it for any reasons. And the second, we will talk mainly the second part of it today, and then the third part will be around November. We did not pick a date yet, but it will be around November. And then we have like another 2 parts for like to finish the whole mechanical ventilation. So that's basic of mechanical ventilation for a critical care trainee or pulmonary trainee. And then by like after we finish this, we should go in more in depth on mechanical ventilation. So the case that we talked about in the first presentation, we talked about this patient who is a 56-year-old smoker, male with past medical history of severe COPD, Gold D, with recurrent exacerbation, that he was presented to the hospital because of symptom and signs suggestive of COPD exacerbation and pneumonia. And we found that he has severe acute hypoxic respiratory failure, and it's not working. Okay. And we did a chest X-ray. We found he has right upper lobe infiltrate or airspace disease. CT scan the same. So the patient was put on mechanical ventilation. So we talked about in the first picture, but we don't want to spend time on this. So for here, we mentioned that to improve. So mechanical ventilation, it's not separate entirety. It's like there's ventilation and oxygenation. Both are related to each other. I don't like when someone starts thinking, if it's oxygenation, we're gonna affect the FiO2 and PEEP. If it's ventilation, is respiratory rate and tidal volume. It's one lung. It's like one unit. You have to think about it. If you change something, it might affect the other entirety of the disease. So if I have problem with ventilation, so if you have not a good ventilation and you don't have a good tidal volume, so you don't have sufficient volume to go to your lung to give you a proper oxygenation as well. And the opposite same, like if I give you a lot of FiO2, but I'm not putting you in a appropriate tidal volume, appropriate respiratory rate, that will affect your lung mechanics and that will affect your oxygenation and ventilation. So, but that way for board, like if you think it's a problem in ventilation, that's what you need to fix, the respiratory rate and tidal volume, and oxygenation is the FiO2 and PEEP. However, as a physician, you need to think about it as a whole unit, not just like, he is having high PCO2. Let's just increase his respiratory rate. Let's just decrease this. Or no, think about the whole disease, the whole pattern, and then adjust, okay? So we look at our patient at the beginning, which that's our patient after they put him on mechanical ventilation. We found that he has this wave. So we talked at the beginning on the first wave, which is the pressure wave. So the pressure scaler in here, we talked about it and we tried to dissect it in each point and know exactly each changes in this wave. What does it tell us and how can we interpret it and how can we use it to help our patient? So a quick review for Katie. So we have in here the first scaler, which is for pressure, and the second one is for flow, and the third one is volume. It depends on what mechanical ventilation you're using. Some of them, they have only 2, and then you need to change the settings to make it 3 waves, 3 scalars, or some of them, it has like all of them like on the screen. But usually it's pressure, flow, and volume. Most of the common use mechanical ventilation in the United States. Okay, so when we talked about pressure, so we divided the pressure scaler to multiple points. And the first point we talked about, which is the peak pressure. We said like when you push the airway, so it's the pressure required to push the air inside the airways and the alveoli. So it's the pressure required during dynamic status. Is that right? Not static status. So I need to push the air. So if I ask someone to take volume, put it inside the lung, I need power to push that volume inside the lung. And I need to face resistance from the flow, like from the airways and the alveoli. So if there is changes in peak pressure, it might be problem with the resistance or problem with compliance. Is that right? So that's the peak pressure. And then we say that's like when the peak pressure goes inside the alveoli and we stop. If I ask you to take a deep breath and hold it, then there is no flow goes in. There is no dynamic status. Is that right? It's only static right now. There is no air moving. So that's what we call the static status in here. Even if there's no air moving, yes, we have surfactant in our alveoli and we have a little bit of pressure that keep the airway open, but there is a pressure on the mechanical ventilation that will keep the alveoli open during that end of inspiration, which is the plateau pressure. Is that right? So the plateau pressure will give us clue about the static pressures, not the dynamic pressure. Okay. So and that's to keep the alveoli open at inspiration. So if I have a problem with both of the pressures, we said in the past, if we have a problem with the peak pressure and the plateau pressure both together, so this is most probably a compliance problem or elasticity problem. So, but if I have only a problem with the peak pressure, this goes more with resistance. Okay. So, and we say the difference between the peak and the plateau is the resistance, and the difference between the plateau and the peak is the compliance. Then I can go more. So we talked about the inspiratory hold and how we measure the plateau pressure, okay? And in here, we talked last time about like when we look at the mechanical ventilation wave, we can see if the patient is like doing any pressure or he's triggering the vent or not. There's a lot of mechanical ventilation. There is a color change. You will see if there is color change, that the specific color, that's a spontaneous breathing. If it's not, however, you will see like if your patient is triggering the vent, that the patient is trying, is that right? Trying to take a breath. So when your patient is trying to take a breath, means he will use his inspiratory muscles, which is the main muscle is the diaphragm. So when he does that, trying to bring the pressure down, it's always positive pressure, is that right? During mechanical ventilation, it's always positive pressure, except if I have like a bad, very bad desynchrony. But in a normal person, so you will see this drop in the pressure in here before the starting of the breath itself. That's when I know this is like has been triggered by the patient. If there's nothing changes in the pressure and the patient and there is a normal breath, so I know this breath was not triggered, this breath was triggered. And it's very important for a physician to know if the patient is triggering the machine or not. Okay.
So if the patient is triggered here, machine will give him, or that depends on his effort?
That's a good question. So it depends on the mode that you are using. Let's say that the patient, you are in VC-CMV, like your patient in volume control, and there is a set volume that the patient will take. Is that right? So when you take the breath, so the machine will assist your breath. So when you take the breath, the machine will assist your breath to give you the exact volume. However, if you need more, that's when you start seeing dysynchronous. But if it's like if there is a mode, different lecture, but there is the SIMV mode, then sometimes like there's multiple like SIMV modes. Sometimes, oh, if you trigger the breath, I will let you do the whole thing by yourself. If you don't trigger it, I will give you the breath. And there's some of them no, like if you trigger the breath, I'll give you everything, like I'll give you support to reach a specific volume. Some of them, if you trigger the breath, and then like I will just observe you. If you get enough minute ventilation, I will not touch you. But if you don't get enough minute ventilation, I will help you. So there's multiple different modes that we can use, okay? But that's a different topic. All right, then we figured. All right, so for just that's a quick review for you. So for today, we'll talk about the PEEP, compliance, and the flow wave, okay, and tidal volume. So when we start our talk, like the same patient, that I'm looking at this flow wave in here. So what do you see abnormal in this flow wave, Ramsha? I mean, in or wave, sorry, not just flow wave. Is this a triggered breath or not? Is all the breaths are triggered by the patient or not? Good. How did you know that? Okay, good, awesome. So in the pressure scaler, what's abnormal? What's like we should do something, we should change something? The peak pressure is high. What's your regular peak that you're looking for?
Just can vary, but it should be less than 35 in
Good.
People, but it's not a fixed number.
Good, awesome. So there is some individuals that we will variate, but clinically, like generally, it's like we need to keep it less than 35. But in here, it's high. Is that right? Okay. So what do you need to do to know if it's compliance problem or resistance problem?
Check my plateau.
Sorry. Okay. We don't have it in this one, but you're right. Yep. And then, okay. So what's going on? Let's keep Katie now. Like you did a good part, Ramsha. Catherine, what do you think?
Possibly the patient is trying to like pull more than what the vent is.
And so we're like, good. So that's a good point. So is the flow in this type of mechanical ventilation is a constant thing or it's a variable thing in a volume control? Yeah.
The flow,
Yeah.
it just delivers one breath and then.
So what did you get my question or not? So
Not sure.
that's okay. Yeah, yeah. So like what's the variable in volume control? Is it the volume or the pressure? Like the thing that it's the
volume.
machine, the machine can play with it by itself. Not me as an like when in volume control, when I put patient in volume control, what's the machine that can change up and down without my permission? The volume or the pressure? That's right. So because I asked the machine, hey, I don't care how you will do it. I need this pressure to be delivered, and the machine will do. This volume to be delivered, and the machine will change the pressure. Okay, and the flow in the volume control, so it's constant flow. It depends. We don't want to go deeper, but in a square form in here, it's a constant control. Okay, so what does that mean? What does that mean? Constant, fixed.
That's gonna be whatever you give title volume, that's we're gonna get there. So that's gonna be something fixed. Only thing gonna be change the pressure.
Okay, so why did I brought this question? Is that right?
I mean, if you have the.
So can we see that on the flow and volume control? If the patient is pulling more or not, and how can we see it?
Yes, I mean, if this is a square, is it volume control?
Okay.
And if the patient trying to pull more, you will find in the expiration, there is.
Another notch
The-
that
the-
patients try to get.
In the
more.
flow.
Usually the better is
What think you in the flow? Yes.
and the pressure, but I think in the volume, I think you can see it too. In the
You
flow.
can
No.
or you cannot.
No,
No.
unless it is.
I mean, the
APR.
volume,
You can't-
the machine,
cannot
if you
see
look at the number, if the patient trying to get more, if you look at the number, you will be variation. But if you look at the volume scalar, it's gonna be the consistent.
The flow scalar, yes.
flow,
The volume, you're right. If I'm giving volume, it has to be stable, and the flows as well. The flow is constant. This flow curve should, if it's like a straight volume control, a set point, it should not change. You cannot see if the patient like trying to pull, if it's square constant flow, you should not see the changes. What's the change? Where you should see the changes if you are pulling more or not? On the pressure, which that's the variable. So I'm controlling the flow and the volume. So I will not see it in there, okay? I will not see it during expiration or inspiration. What I see in here, what's this? There's no flow in here. Is that right? And there is like something down in here. Is that right? In our COPD patients. So then let's talk about this. So when we during inspiration and keep the alveoli open is the plateau. Good. And what's about end expiration?
PEEP.
So PEEP. So this alveoli in here, it doesn't have any like PEEP. That's an expiration without PEEP completely. Okay. And this one has 5 of PEEP. And this one has 10 of PEEP. The thing is, clinically as a physician, it's easy to memorize. Oh, let's just put 5 PEEP, 10 of PEEP, 12 of PEEP. But the main important thing is to think about it. What's the enough PEEP for this patient? What's the PEEP that will lead to more rupture or a PEEP that will lead to recruitment? And we'll talk about this more, okay? So there's a video in here. Okay. They want us to.
Click on that one.
Okay. It is. to see how the recruitment of the lung. That's a rat lung, by the way. See when he's start increasing the PEEP, it doesn't go back to 0 again. So it's like, but the thing is, it's not just like the, oh yeah, just increase the PEEP. We looked at the video and it's like opening the lung. You have to be like, what's your limits, okay? And we'll talk about that. You got it, guys? Right. Good. So when we look at that, when we said we looked at the pressure curve, and we said that's the peak pressure, the plateau pressure, and the PEEP. We talked about that in the last lecture. So when we look at the PEEP, the positive end expiratory pressure, so how do you look at it when you have patient in mechanical ventilation? Do you look at the number that what's the PEEP are you giving, or what do you think? Like how do you look at it? Let's start with Ramsha again. The question is, how do you look at the PEEP? Like, is it like when Dr. Jasmine say, hey, how is this patient PEEP doing? Okay. Let's say that, so PEEP is 5, so you will go back to Dr. Jasmine and say, hey, this patient is doing a PEEP of 5. Okay. So yes, from here to from 0 to this level should be 5. Is that right? Okay. Katie, what do you think? Like, is that the actual PEEP that we are giving the 5, or we should look at different things? No, go keep.
We can add so total the pressure we added. So EPAP we add that 5 plus 5, that's 10.
5 plus 5 plus 10. What's that? All
Oh,
right, Katie. What? Anything else?
yeah.
So you're asking if just.
So how, like, Dr. Jasmine sent to you and say, hey, can you please check how much, what's the actual PEEP of this patient?
The numbers.
Okay, second year.
Do some math.
Okay, second year. What's that?
So gonna check.
You can go ahead. Go ahead.
Yes,
No, I was just gonna
yes,
an
go,
expiratory
yes.
hold thing. You can check.
Okay, so you will do expiratory hold.
Yeah.
All right.
But also you need to check for other numbers to know.
So you will do,
appropriate or not.
so like the number that you are giving, it doesn't mean that the patient is getting that PEEP. So if the patient in 5 of PEEP, it doesn't mean that for sure this patient in 5 of PEEP. He might have O2 PEEP. He might have any problem that increasing his amount of PEEP. So that's why we need to do like an expiratory hold. And we have to see, guys, I've seen that done a lot. Patient expiratory hold, and the curve will be like moving up and down, and the machine will give you a number and you will just take it. If the patient is doing an effort and there's some changes in that line, it's not a straight, steady line, you cannot take it. Or you can do it by yourself, like freeze the image and you go, where is the exact steady line, and then you measure your PEEP. But if it's like, there's a lot of effort, like you are doing expiratory hold, but the patient is not holding, like he's having a lot of effort, or the valve of the expiratory hold is not working well, you will see like some leak or some, so don't just take it from number wise. The machine can make mistake. We build the machine, is that right? All right, so that's the PEEP. So this. All right, so like, why do we care about PEEP? So from the video and everything, why do we care about PEEP? Why we didn't just like don't give PEEP?
Because it has benefit and risk.
Okay.
Avoid barotrauma or atelectasis. I mean, if you have low PEEP, if you have higher PEEP, it's gonna be.
So high PEEP, you avoid barotrauma, and if you low PEEP, you have you. Oh yeah, you're right. Okay.
From atelectasis.
Okay.
And that's can cause the hearing.
And it can affect you, the patient hemodynamics too.
Good. Good. So like that's why we always need to choose the appropriate PEEP for the patient. Is that right?
Individual patient.
That's right. And the other thing that we use PEEP to look at our compliance. Is that right? And like these, like it's very important to like to see if the patient is like has a good compliance or not, not, patient has poor compliance, high compliance, low compliance, patient has high driving pressure or not, and we'll talk about that more. So if I'm not giving a good PEEP, as Kareem said, and it's like it's not the number that meet the physiological PEEP that the patient required in this disease, because he's not a normal patient, is that right? The patient has a disease in his lung. So then I might be having what we call low volume lung injury. But if I increase the peak, or I increase like a PEEP, we'll have like a high volume lung injury or high PEEP lung injury. So that's why we need to keep my patient in this area, which is the like the protective area where the patient will have enough PEEP, enough pressure, enough. Okay. So going back in the same patient. So this patient, we have a peak and plateau pressure. What can we get from the peak and plateau pressure? As we said, what can we calculate? Okay, so you can do the compliance from the peak and plateau. Okay, so what's the compliance from the peak and plateau? No, you're good. You're right. Okay, volume divided by pressure. The difference in volume divided difference in pressure. Okay, what pressures? So I sent you to calculate the compliance. Awesome. Good. Dynamic or static. I sent you to do the dynamic. That's right. Good. So dynamic means that there's an air moving. So I need the dynamic compliance. So it's like the positive inspiratory pressure, like the peak pressure minus the plateau pressure. And then we have the delta volume at the top. Like if this patient we have 400 volume, so the 400 divided by the peak minus the plateau. Is that right? Okay. What else that you can use from these two numbers? So we said resistance. That's right. Driving pressure, not from these two numbers, but resistance. So resistance, why do we care about resistance? Okay.
Sometimes you have to change the circuit. Sometimes there's kinking of the.
So there is something in the tubing, there's something in the machine, or something in the airway itself. So resistance, it will be counted for all the tubing to the like if you have very small tube, you will have high resistance to push the air according like that 6 millimeter of tube. Is that right? If you have like 8, maybe you will not have that much resistance. If the airway have severe COPD and hey, do you know what, Dr. Megri, I think this patient is improving, and we intubated him only for severe asthma. And we have patients like that when we were in ICU. So only for severe COPD. Okay. So if I come today and we did that and we measure the resistance, and the resistance is like, say, like it's 20, and tomorrow I come, oh yeah, I think this patient is improving dramatically, and I measure the resistance still 20. There's no improvement, is that right? So you need to make sure, like, is my resistance going down or not? So how can we calculate resistance? So resistance, it's mainly like when we talk in here, and always put it in your mind, guys, when I talk about resistance and third year, do you know what's the equation for resistance?
Pressure
Good.
gradient overflow.
Good. And what type of pressure you use? Okay, so what type of resistance is that? So that's inspiratory resistance, is that right? So you're not looking at the expiratory resistance, is that right? So we have some patient, don't always forget that when you come in and, oh yeah, patient is doing fine. So I have some patient during exhalation, that's when they have like, and that's in COPD patient, when you look at them, like they have resistance during expiration, is that right? We have like the air trapping and everything goes during expiration. So when we do this calculation, mainly we are calculating the resistance during inspiration. Okay, peak minus plateau. So we said airway resistance peak minus plateau divided by flow. Normal should be less than 10. That's the lecture and slides. How you do it in the real patient. Have you ever, anyone of you done it, guys, before? Yeah, third year, second year.
Yeah.
Yeah, how you do it? Just let me know. Like you went to the patient, there's a mechanical ventilation. Yeah.
You see the flow over 60.
Awesome. Good. That's what I'm looking for. So the flow in here, the flow in your machine, like there's a flow per minute or there's a flow per second. Okay. So when we look at the flow, like the flow that we have it in machine, we divide it by 60 to get the actual flow. Okay.
Yeah.
How can you make it easier for you and very easy calculation? How can you get that flow out? Was that? Yeah, right, Katie, you said something. Just make it 60. Just in that time when are you calculating, just change the flow if you are able to with the changes in, we'll talk about it. But you can change the flow to 60 and that's one, it's gone, is that right? Then your resistance is peak minus plateau and that's it. But just don't change the 60 and change the 60 at least a minute to give like, because when you change the flow, the peak and plateau, it will change. So that's why you need to give it a little bit of time, at least a minute, and then look at the numbers and then that's how you will know your resistance. And document the number. Next time you will come and do it. Our new machines is very like amazing. Like we have points in it, which is you will give you the resistance by itself. If you just like slide the screen to the left, it will give you the resistance and how much the resistance if and it will calculate it by itself and it'll give you the resistance number and then you can follow up and see. That's the expert monitoring that you go to it and it will give you the resistance and how much the resistance today, how much the resistance tomorrow. Do you know, guys, do you have the app for our machine? Okay. Yeah, I will send it because like they put it in and I did not have, I've never worked with this machine. I don't know if you have, so they just put it in like, hey, play with it. So, but there is an app, I will let you know about it. You can open and there's a lot of lectures that it will teach you about the machine. Yes.
Just the flow, you mean the flow, the FI2, you mean the flow, the inspirative flow?
The flow, the inspirative flow that we like, do you know when there's flow?
Because the new one, we don't have it. That's the new machine. We don't have the inspirative.
No, when you open it, there is flow, but you cannot change it in each mechanical ventilation. How can you change the flow? That's right.
Yeah, that's
So you can change, there's two ways. There is a way how to change the flow, some of the mechanical ventilation. There's a different mechanical ventilation that you have to change the inspiratory time, and that will change the flow.
That's the new one.
Yes.
Yeah, we don't have the.
Yeah, you change the inspiratory time, that will make your flow.
But
Yeah.
every ventilator has a flow, it's just how it shows it to you. So some of them you can change it and some of them you have to go find it. So
That's right.
They all have flows.
All right. So that's resistance. What's the resistance we look for? Less than 10. So if you have a patient who has like a mainly intubated because of high resistance Ramsha, what you will do, you will document the resistance in the first day, do your intervention, and then try to see if that resistance is going down or not, clinically and number-wise. Is that right? All right. How can we do the compliance? So we said dynamic compliance is the peak minus the plateau. But do we care mainly for dynamic or static? Why is that? I wish I didn't say it. Okay. So why do we care about like, actually I care about both of them. Like to understand the lung mechanics, I need to know both of them. So like you need to know like your dynamic but the main thing, like if I tell you like, oh, this patient, and it happened in COVID, you know, like at the beginning of the COVID, oh, his compliance is normal. That's not an ARDS. And actually I have heard, like I was a fellow, but like I've heard a lot of like faculty, oh yeah, it doesn't look like an ARDS. His compliance is normal. Do we have a compliance in the definition of ARDS? Like when we define ARDS? So we don't know what exactly the normal compliance for this patient, but there's an entirety of disease like patient that they have ARDS with normal compliance, but doesn't mean anything. Doesn't mean like, oh, we'll change the management and we'll do different scenario. It's just like looking at the compliance for myself, I look for improvement. So if I come today and I do a static compliance and I do my interventions and do my recruitment and do everything and then recheck my static compliance, if it's improving, I know there is recruitment of the lung. Is that right? The size of the lung, like static wise, it's improving. There is more alveoli has been recruited. So now the pressure that I used to give to 2 alveoli, it's now giving to 10 alveoli. Okay. So that's why the static compliance, I care about it more. Not I don't care about dynamic, because like it gives me more clue about recruitment. So when I come to my patient, I know how to calculate the plateau. How do I calculate the plateau, Katie? Plateau pressure. Good. How many minutes you need to hold? Okay, good. So how many seconds you need to hold? That's right. 3 seconds more than enough. 3 seconds, you can get your plateau pressures, okay? So, like actually, if you put your mechanical ventilation on 15 milliseconds, it's enough to give you, you know, like there is a pause in the mechanical, you can pause it like for a, like you do like inspiratory pause in the mechanical ventilation. So usually if I have a COVID patient and I don't want to go in and out multiple times, and patient has high PCO2, I put like pause of like 15 milliseconds, and that will give you like sufficient enough to give you like the plateau pressure. It will like be reading on the machine. However, now, so you pause the machine, you get the plateau pressure, okay? And how you calculate the static compliance. Good. So what PEEP you're talking about? That's right. So you need to make sure what PEEP is like the patient is what I'm giving to the patient is what the patient having right now, or the patient has like a big difference. If it's like 2 to 3 difference between the actual PEEP and the real PEEP, there's no big difference. If there's like a real O2 PEEPing, that make a difference in your calculation, is that right? And you have volume. So what's your normal compliance? Ramsha, what's the normal compliance? So if you see, oh, that's normal. It's not percent. Yeah, like 100. Okay, Katie, what do you think? Okay, good, awesome. At least like better than last time you were here, guys. Like I was like, what's the normal compliance? Oh, 13, 15, 20. So good. So that's like it's had like more than 60. We say it's okay, but normally in us, like we say like 100, 120. That's a normal compliance in a normal person. But more than 60, we'll say that's a normal compliance. So you check the compliance to make sure. That's the other problem. So when you do a like an inspiratory hold, your patient can breathe not breathe. You blocking the valve, is that right? There is no air moving, but the patient can do accessory muscles use. He can use his diaphragm, and that will leads to not plateauing line. It will go up and down, and the machine will just take the average or will take the highest and give it to you. So you have to look at the curve when it's plateauing, where exactly you need to see it. When it's plateauing, that's when I gotta take my exact plateau pressure, not just taking any pressure. Okay. All right, driving pressure. Who will tell me like why do we even talk about driving pressure?
Yeah.
Okay.
Study showed
Study showed what?
less than 15 per mortality.
Okay, so they like they did the
Mortality.
prospective trial and they looked at a patient and they adjusted the driving pressure and they found less than 15 that improved mortality.
I think so.
You think so?
I think it's retrospective.
Yeah.
Last time.
It's indirect.
It's
Yeah.
retrospective data.
Okay.
They reviewed retrospective data in the past and they found it was like it's like was not the primary analysis, was like they did.
So they went back in a trial and they found that the patient who has driving pressure less than 50 has better outcome. 15, sorry, not 50. Yeah. Less than 15 has better outcome. But till now, I don't know if there's like a new, like a big study. Till now, all like physician has different aspect of driving pressure, which is the plateau minus the PEEP. Okay. Some of physicians, they work to make it less than 15. Some of physicians, they just look at it as a parameter that, oh, if it's like keeping more than 15 for multiple days and it's so I cannot change anything, that's a poor outcome. If you ask me, like personally, like use of driving pressure, so I think about the patient as a whole. First of all, are you putting your patient on the appropriate mechanical ventilation settings or not? So what's that question? What does that question mean? So if I have an ARDS patient, and Saddam put him on 10 of PEEP and 400 of tidal volume, and that's 6 ml per kg, and the patient is saturating like 92. And his peak pressure is 29. Okay, that's like a fantastic ward, is that right? We don't have like high peak pressure, we don't have high plateau pressure. Would you like to change something in this patient or not?
What's the beep you said, sorry?
We said the PEEP is 10, volume is 400, that's 6 ml per kg, ABG looks fine, PO2 is like around 60. Saturation is around 91, 92. Peak pressure is 29
What
or
is the
26.
plateau?
Plateau is around 25.
Yes.
Go up on the peak.
Okay.
Think you are stressing the line more.
So you would like to see if what you're saying, this PEEP is enough, or can I give more PEEP
Yes.
to recruit more?
Yeah.
So higher PEEP, it will not improve mortality, is that right?
No.
Improve oxygenation. There's one study showed that maybe like a higher PEEP, like improve survival in ARDS patient, but there is no, like we cannot answer the question higher PEEP is improve mortality, no. But the thing improve oxygenation. So I need to know if this PEEP is sufficient enough. So now the plateau we said is 28, is that right? 28 minus 10 is what? 19, is that right? 18, sorry. Like if you look at it more, it might change to 19. So it's 18, is that right?
Yeah.
So that's more than 15.
Yes.
Okay, but you know what, Dr. Jasmine? His driving pressure is more than 15, and I think that's a very bad outcome for this patient. But if I come, they said, you know what? Let's just increase the PEEP a little bit. So what will limit my increase in the PEEP? What things that you look at?
The
Peak. So I went up to 12, and his peak went up to 29.
So the beep, what limit your beep, the plateau and hemodynamics?
Okay, you're right. What do you mean? Like this patient?
If you
Give me
increase-
numbers.
If you increase the beep, the plateau will go up sometimes.
Okay, I went to
If the
12.
lung-
I went 12.
If the lung has no compliance.
Okay, so I went from 10 to 12.
Uh-huh.
The peak pressure went to 30. It was 28. What would you do?
So it is still long.
You still
You're
have-
not recruiting more. You're not recruiting more.
Why is that?
Because the peak should go down when you recruit more long.
Good.
More
That's
alveoli.
So that's right. So when I go to PEEP, it should go up at the beginning because the machine will not give like in this.
Then when
You give it at least few minutes and come back.
Mhm.
If it go like from the beginning, two in the PEEP, two in the peak, then sorry, in the plateau, there's something wrong going on. Maybe like I'm just stressing the same alveoli, but give it a little bit of time. I'm not in the range where is the barotrauma, is that right?
Yeah.
Give a little bit of time and see if like that's okay or not. But I can recruit. I'm still safe, is that right? If I go more in the PEEP and it went to 35, I went to 16 PEEP, 14 PEEP, which is only 2, and my plateau was to 35. That's obviously that you're not recruiting. You're just like increasing more pressure. It's still less than 35, but you need to understand. No, I'm not. I'm just like stressing my lung more, and that's increased the pressure. Let me go back down, give the lung some time, and come back again. Because if I go 2 and it goes 2, I go 2 and it goes 2. Did you change the driving pressure? You did not change the driving pressure. Is that right? But if I go 2 and it goes only by 1, and then after 5-10 minutes it goes back down the plateau pressure and stabilize on 28, I recruited more. Is that right? Because I gave PEEP, the plateau pressure did not raise and maybe even go down. So I'm recruiting more. The other thing which is very important, but we'll talk about it in a different lecture, the stress index. Okay. All right. Now we talk about the flow. So the distance from here to here, that's the inspiration, is that right? And now we know in volume control, the flow is not variable. It's constant. Is that right? It's constant. So I should not look at the flow to judge what's going on in the lung mechanics. So this is inspiration and this is the expiration. I need to know what's going on in my scalar. So now we know the pressures, is that right? You know exactly where's the peak, where's the plateau, how you look at the resistance, how you look at the compliance, how you look at the patient triggering the vent or not, and how you're looking at the O2 PEEP and the plateau calculation. Good. So flow right now. Dr. Megri, if it's constant, like why even like we talk about it in like a volume control, is that right? If it's something constant, how that it will give us like how can we use the flow? Yes, we can use the flow to calculate the resistance. That's one. And why we're looking at the flow?
Something like
About the elasticity of the lung and the resistance is another.
if there is auto PEEP, we can tell from the flow.
Good.
Mhm.
O2 PEEP. What else?
There is any airway obstruction.
Good. Resistance like during expiration. Because when we did the calculation, we did the calculation mainly for what? expiratory resistance, is that right? We did not look at the main expiratory resistance, okay? So when we look at a flow, the main thing when it's volume control, I look at the expiratory part, okay? If it's not volume control, you should look at everything. But if it's volume control, the expiratory part, that's what I look at more. I look at if the patient is having obstruction, having auto beep, as you said, guys, or if the patient trying to exhale before or after that, we put the time for them. Okay, so in here, that's the patient inhaled. The flow, like when we inhale, the flow goes straight. So is this a normal, like if me and you right now, if like I take like a gram that to give me exactly the flow while I'm talking and breathing, does it look like square like this?
No.
How you think that it will look like? Like what? So it will go peak and then slowly decelerate. Is that right? That's how usually. That's right. So it will go up at the beginning because of the difference of pressure to reach the peak, and then because the pressure start equalizing, the difference between atmospheric pressure and my lung pressure, the flow start like going down slowly. So decelerating flow, not the constant square flow. Is that right? So that's what we are doing, constant square flow in here. So if you're around with me, I like to put the patient in constant flow even for one time. Why is that? It's just like because that's how I trained, or why I like to do that. That's right. When your flow is constant, that's more accurate measurement. You know more about, like you took one thing out of your equation and you know more about your lung, like mechanics, because that, like the peak, how really the peak is, what's the stress of the lung is. So that's why my advice to you when you're going to do like calculation and it's very important for you and you don't want to have like a lot of variable changes, I will change it to a square test. Square flow, and then we'll go and then my measurement. Okay, so that's what we call it about that. We didn't need to talk more about it, the delivered PEEP. And so what do you think about this flow, Ramsha? Normal, abnormal, good, normal, abnormal. What's going on? Inspiration is not good, or what's going on? Expiration is not good. You're planning to say something.
Yeah, in the previous one, I saw that the dotted line was touching the baseline. So maybe there's some kind of.
Good. So why it's not touching the baseline? Patient or the machine? Machine, maybe. Is that right? It's constant. So we are giving, maybe we are not giving time. That's a good thought. Yeah, we are not giving a good time for expiration. What else? Or maybe you are giving a long time for expiration, because if you look at the numbers and at the shape in here, it's obvious that expiration is more than inspiration. Is that right?
Yeah.
But this patient is not normal person. Maybe he needs more expiratory time. Like in who? Like in COPD patient, asthma patient. That's right. So I need less, like, so that's no, like, is this for sure auto beep or not? It's like, oh, that's very harmful. Let's do something right now. You just looked at the flow. So you suspect there is an auto beep, and then you do, like, you have to do expiratory hold and you look at it, okay? Because there's might be some a little bit of difference that is not significant in your patient. So you don't have to worry about it, like just give them time and it will improve. But if there is a significant difference, which is more than 5 in your actual beep and the beep that you're giving, that's when you need to make, oh, I need to do some changes. However, me, myself, like even if it's not significant difference, I will just try to get rid of it if I will not affect the other lung. So that's a very good question. What, like as you know, like one of the main thing for like COPD patient and asthma patient is looking at the inspiratory to expire. Like if I'm not intubated, I'm not intubated. So and you look at me today and you see like I have very prolonged expiratory, like I will breathe like this. Tomorrow when you come, after you give me treatment and everything, I'm breathing like this. So there's decrease in my exhalation time, is that right? So maybe you opened my airway, is that right? And I had like, I was able to get out volume rapidly comparing to before. But it depends how the way I'm breathing. I'm not breathing like this. That's different. That's getting worse, but like it's just the time decreasing. Normally, my expiration time is more than expiration time. So like 1 to 1.2, like or 0.9 to 1.2. But is there a number that I have to target when I do the mechanical ventilation? No. It depends on your patient. 1 to 1, that's the lowest. You don't want to have reverse. Is that right? Except some expert said when the patient is having severe hypoxia, I need to give them like a little bit of more inspiration time during that time of severe refractory hypoxia, just as a bridging until I do something else. Like I give a high PEEP, reverse the time, giving like a lot of inspiration, just I fix something and then I'll come back and fix it.
We have tried these, but it increased the pressure.
Yeah, it will increase the pressure. Yeah. I'm not in, like, as I said, bridging. I'm believer of there's something else you can fix, not just the inspiration time and expression time. All right. Wow, there's something different in here. You still have O2B, but there's something else, Katie, is that right?
So within the expiration there, like a steep drop and then or kind of leveling off.
Good. What does that tell you? So the air, like, let's just think about it like loudly. So the air went in and during inspiration, flow went in during inspiration, it filled your lung smoothly, is that right? And then now the valve opened, is that right? And your volume will go out, is that right? And the flow will go out. Usually it should just go out slowly. You just opened and slowly until you reach the base. But in this period of time, it went back up like to the like close to the baseline quickly, and then it's slowly gonna go back like obstruction. That's right, obstruction. But you think of these like usually it's like in a small airway obstruction, and then like it like small airway and you start up slowly. So the thing is, this sometime happen normally in some patient if I did not see the O2 beep. If there's no O2 beep and it went up quickly and then starts slowly going up and maybe it will go back down a little bit in here, that's when you have high elasticity in your airways. You understand what I'm saying? The volume went out at the beginning quickly, so it's like collapse and then start back again and slowly going up. But you will not see O2 beep. Your clinical story is very important. Is that we are not RTs, is that right? So you have to like think about the patient. What's the mechanic of the lung? It's not just fixing the mechanical ventilation. What's the story behind this to say if it's obstruction or not?
That's normally said, sorry.
No. Like in here, yeah, so it's they have an O2 beep. I have a history of COPD in this patient that we admitted,
Okay.
and we have this. This is an obstruction.
Okay.
Indicates
There is an obstruction.
Okay.
One time we have patient Dr. Shui had tracheobronchoparesia actually didn't have the same exact thing.
That's a good point because there is a lot of elasticity. Is that right? It will hit all of a sudden, and then that's what we'll see. Okay. So these are the types of curves. We have square, decelerating, accelerating. I've never done accelerating. It's like square or decelerating. Okay. Which one is better for someone who has COPD? Let's start with Saddam. Yeah, or asthma. Good. Anyone else? Hamza.
Constant.
Okay. Kareem. Deceleration. This side is deceleration. This side is constant. Katie. Gonna follow Hamza or?
But is there any difference in expiration here?
So let's skip. That's a good question, but that's okay. Deceleration or constant?
No,
Deceleration, constant.
no difference because the expiration is.
He changed his mind. Okay, so for COPD, it is constant. Why is that? Because if you do deceleration, that usually it will increase your inspiratory time. It will take a longer time to get all the flow out during inspiration. That will lead to what? Decrease your expiration time. Okay, so So that's why in the constant, you have like flow done and that's it. So when you have like patient in COPD, if you would like to give him like constant, that's one of the things that will help you to increase your expiration. But for patient comfort, usually deceleration is the way how the patient is comfortable more, because that's like it goes like a normal physiological one. So that's our patient. I'm done in 1 minute, guys. Sorry. So acceleration. Okay. All right. What do you think about this patient now? So now you have plateau, Ramsha. So peak is 51, plateau is 30. What's his resistance? Let's make it quick, guys. We don't have Rami, unfortunately, so we need to use calculators.
50.
So who gonna do it for us? Katie, do it. Everyone else do it in his phone.
Oh, I should do it in my head.
No. You do it in the, like you're gonna speak. No, I'm bad in math. So you're gonna speak loudly. What are you doing?
The resistance, I want to do the peak minus the plateau, which is 21, and then divide that by the flow.
What's the flow
But
in
the
here?
Flow has to be 6, it has to
So
be within
50
60,
divided by
50
60.
So 21,
26.25.
So we did the peak and the plateau after we did the inspiratory hold. Is that right? And we make sure that's a good plateau, and that's the resistance. But I have to do expiratory hold or not? Do I have to do expiratory hold to calculate the resistance? The resistance.
No.
There's no need. But I said we are not like just thinking about one number. I need to see, is there an O2 beep or not? Is there an expiratory resistance or not? So it's better to have a good full picture, inspiration and expiration. However, when I calculated 51 minus 30 divided by 50 divided by 60, is that right? And it was 26. 26 is normal. So it's very high resistance, and that's the COPD patient. So we need to work on it. Is that right? We need to help this patient. All right. And he has O2P. What's his compliance, Ramsha? Static compliance. Do the calculation. We said static compliance. So speak loudly.
So
Like
I'm
Katie.
trying to deduct the time volume by plateau minus.
Peep,
Yeah.
which is divided by the driving pressure. Is that right? So plateau, which is 30, minus the peep, which is like the, what's the peep in this patient? It's 5. No, it's not 5.
11.
That's right, because the peep in here, like it's 11 in the right side. You see it? So that's the actual peep. The 5, that's what we are giving, but the patient is O2 peeping. Is that right? So the static compliance is 27, and that's what?
Low.
That's very low. Is that right? That's a very low compliance. So this patient has high resistance because of COPD, and he has low compliance because of the pneumonia he has in the right upper loop. Is that right?
volume.
Can't tell from
It's
the
like the
pressure
delta
curve, it's
volume.
more high because
That's right. What's that? Sorry.
It's not the delta volume, it's the tandem volume, the inspiratory tandem volume.
Okay.
Katie, you're
So
asking
you don't
about
like, you don't see like
compliance.
what's actually like.
No, you see. That's a very good point. You see what's the patient volume is, because I'm giving 520 and the patient over there is 520 in the left. That's the patient, the one on the left. So he's getting the volume that I'm giving. Don't use the volume that you are like in the machine. Look at the volume in the machine. Maybe he's doing 600.
Yeah.
Is that right? Okay, we're done.
Thank you.
Any questions?
Machine, they said you can use like the iPad to do B plus the pressure support, and you consider that as